transfer.
Okay, thank you very much. So in this presentation, I will talk about clinical effectiveness of combined treatment of hyaluronic acid and prolactin before blastocyst transfer. I have no COI to disclose in this trial. So as a previous presenter mentioned, the frozen embryo transfer have progressively increased worldwide. However, pregnancy outcomes after frozen embryo transfers remain at the same level despite many advances in IVF technology over the decade. Previous study estimated that 50 to 70% of pregnancy losses are attributed to failures in early pregnancy event, which can result from various factors, including chromosomal defect, quality of gamete and nascent embryos, inadequate endometrial receptivity, and insufficient embryo capacity for implantation. A detrimental factor is considered chromosomal defect. In fact, recent meta-analysis reported that introducing PGTA increases live birth rate. However, even after euploid blastocyst transfer, 40% of cases still result in implantation failure. To improve the pregnancy outcomes, we have focused on the embryo capacity for implantation. A possible intervention for improving this capacity is supplementing the medium for post-warming culture and embryo transfer medium with maternally abundant compound such as hyaluronic acid, HA. And the human embryo express CD44, which is a receptor for HA, and the HA is secreted from the endometrium during the peri-implantation period, and is considered to play a role in initial stages of blastocyst attachment and invasion into endometrium via CD44. Furthermore, recent systematic review concluded that adding HA to embryo transfer medium can improve the live birth rate. Therefore, supplementing HA to transfer medium is currently recommended. We have also focused on the endometrial prolactin signaling. Prolactin is secreted in the endometrium during the peri-implantation period, and the previous study reported that insufficient prolactin signaling is associated with implantation failure and early pregnancy loss. Therefore, prolactin was sought to influence the blastocyst implantation. Furthermore, our recent study demonstrated that human embryos express a prolactin receptor and its expression increased after embryo compaction and blastulation. Furthermore, prolactin treatment for 2 hours promoted epithelial mesenchymal transition and integrin-based focal adhesion, improving trophoblast migration capacity. Furthermore, prolactin treatment did not increase the adhesion rate to fibronectin-coated tissues. However, outgrowth area was significantly increased by prolactin treatment. Also, this treatment can decrease the instance of outgrowth degeneration. So, considering the bioactivity of HA and prolactin, we hypothesized that supplementing HA and prolactin to media for post-warming culture and embryo transfer could enhance blastocyst attachment and invasion into endometrium. So, to assess whether combined treatment with HA and prolactin increases implantation and live birth rate after a single vitrified warmed blastocyst transfer, SVVT, we conducted a double-blind randomized control trial. So, in this RCT, a total of 1,236 couples undergoing SVVT were randomized into one of the 3 groups using a computer-generated random number sequence. In the control group, the blastocysts were cultured in standard medium without HA and prolactin. In EG group, HA-enriched transfer medium, embryo growth, was used for blastocyst culturing. And in EGP group, the embryo growth supplemented with prolactin was used for the culturing. And the blastocysts in all groups were incubated for 2 hours and then transferred to uterus in the same medium. And the pregnancy outcomes listed here are assessed. In this trial, a patient and the physicians are blinded to treatment allocation. However, embryologists and laboratory technicians could not be blinded. So this slide shows a flowchart. And in this trial, a total of 10 couples were excluded due to the thin endometrium, insufficient luteal function, and embryo degeneration post-warming. This slide shows the patient characteristics, and there were no significant difference among the groups. And this slide shows a cycle and embryonic characteristics, and they are similar among the groups. And this slide shows the pregnancy outcomes. So although implantation and the clinical pregnancy rate were comparable among the groups, however, the ongoing pregnancy and live birth rate were significantly improved in EGP group compared to the control and the EG group. Furthermore, the rate of early pregnancy loss was significantly reduced in the EGP group compared to the control and EG group. The miscarriage, stillbirth, and ectopic pregnancy rate were similar among the groups. Also, the incidence of maternal and perinatal complications were comparable among the groups, and the infant size and the sex were similar among the groups. So our data demonstrates the clinical effectiveness and the safety of EGP treatment. So we next conducted a subgroup analysis to determine to whom this treatment is effective. Our previous study demonstrated that the expression level of prolactin receptor was significantly correlated with the blastocyst characteristics, especially developmental speed and morphology. So faster growing blastocysts and better quality blastocysts express higher level of prolactin receptor. Therefore, effectiveness of EGP treatment may vary among the embryos. So we first stratified the couples by median female age. When the female age was younger than 38 years, the live birth rate in EGP group was significantly higher than that in the control and EG groups. However, when the female age was 38 or older, the live birth rate was similar among the groups. We then stratified the cohort by blastocyst morphology. When the blastocyst quality was good, the live birth rate in EGP group was significantly higher than that in the control and EG groups. However, when the morphology was poor, the live birth rate was similar among the groups. We also stratified the cohort by developmental speed. And when the embryos were day 4 or day 5 blastocysts, the live birth rate in EGP group was significantly improved compared to the control and EG groups. However, the live birth rate in EGP group was comparable to that of control groups. Although there are no significant difference, the live birth rate in EG group was numerically higher than that in the control and EGP group. We then focused on the prolactin secretion. So prolactin is secreted by decidual cells that are differentiated from the endometrial stromal cells. And this differentiation is induced by several factors, including progesterone. So therefore, in cases with insufficient progesterone secretion, the endometrial prolactin signaling may be diminished. And also, we hypothesize that the EGP treatment may compensate for this insufficient prolactin signaling. So we stratified the cohort by the progesterone level. And when the progesterone level was lower than the median, the live birth rate in EGP group was significantly higher than that in the control groups. However, when the progesterone level is higher than the median, the live birth rate was similar among the groups. So, taken together, our data demonstrated that combined treatment of HA and prolactin significantly improved the ongoing pregnancy rate and live birth rate by reducing early pregnancy loss without any maternal adverse so without any adverse effect on maternal and perinatal outcomes. And this benefit was observed in younger patients in cases with good quality blastocysts or day 4 or day 5 blastocysts, and in cases with insufficient progesterone levels. However, continuous development are necessary to further improve the pregnancy outcomes, especially in poor prognosis cases. I'd like to thank our team and collaborator, Dr. David Gardner, and also we appreciate Vitalife for sharing their expertise for this